Okay, now the second talk that I'm going to talk about is anti-infective or challenges, and particularly talking about antimicrobial resistance. I'll just briefly cover the AMR for systemic infection and then what is the status of antimicrobial resistance in ocular infection. Does it translate into treatment failure, and how do we handle antimicrobial resistance? And what is the value of fortified antibiotic or a combination of antibiotic? I'll just begin with this case of 50-year-old female who presented to us with the redness and pain of 7 days duration, and local ophthalmologist treated this patient with moxifloxacin and atropine, moxifloxacin being administered every 1 hourly. The patient was not responding to treatment and was referred to us. We did corneal scraping and found gram-positive cocci in pairs and groups, which was identified as Staph aureus, but was found to be resistant to all fluoroquinolone, but susceptible to cefazolin, azithromycin, and chloramphenicol. This is yet another case of 73-year-old female housewife presented with history of 15 days duration and was worsening despite treatment with basifloxacin 0.6%, presented to us with the limbus to limbus infiltrate. Here again, the gram-negative bacilli were seen in the smear, Pseudomonas aeruginosa grew, and the antimicrobial susceptibility showed resistance to fluoroquinolones as well as chloramphenicol and intermediate susceptibility to tobramycin. I think both these cases give you a perspective that antimicrobial resistance on in vitro susceptibility tests is not uncommon even in ocular infections. And this is not a new phenomena. Right from the time the penicillin was discovered, there was a note written by Alexander Fleming where he warned clinicians that a thoughtless person playing with penicillin is morally responsible for death of men who finally succumbed to infection with penicillin-resistant organism. And I hope this evil can be averted. But despite that warning, in those days, as soon as penicillin was approved for clinical use and was found to be effective, there were billboards where they were displayed that, oh, now you have penicillin, everything is honky-dory, we can treat any kind of infection. But this is how the whole spectrum changed, and over a period of time, the penicillin started, or organisms started developing resistance to penicillin, and the situation worsened. This is not just the story of penicillin. Any antibiotic that has been brought for clinical use within few years after its introduction has shown the phenomena whereby the microorganisms develop resistance against those antibiotics. Today, World Health Organization has identified AMR as a major problem because it's present all across world. It is not just the serious public health concern for treatment of malaria, tuberculosis, and HIV. It is also not just a hospital-acquired phenomena, but is increasingly being noticed in the common bacterial infection. And today we have organisms which are resistant to multiple classes of antibiotics. This is not just true for methicillin-resistant Staphylococcus aureus, but a wide variety of Enterobacteriaceae organisms are showing resistance to a wide variety of drugs that are listed here. And there is a rise in number of organisms which are becoming resistant to 3 or more classes of antibiotics. What WHO surveillance studies also found that there is a clear association between the use of antibiotic and antimicrobial resistance. And they also found that the time required for development of resistance is much shorter as compared to the recovery of organisms to develop susceptibility on discontinuation of antibiotics. Today we also know that antimicrobial resistance is because of wide variety of phenomena from its use In poultry, animal husbandry, agriculture, the way waste is discarded into community from the industry that are manufacturing antibiotic and so forth. So why are we so concerned about antimicrobial resistance? I think if you look at the discovery of antibiotic, you will find that many more drugs were brought in the market until at the beginning of this century. But after that, there has not been any new molecule that has been brought in the market which is effective against microorganisms. So there is a innovation gap. And with organisms becoming more and more resistant to antibiotic, there is a fear that we possibly may end up having a situation similar to a pre-antibiotic era where we are not left with any option to treat these cases. So is an AMR a problem in ocular infection? I think let me take you back into the bacterial keratitis study where ofloxacin was compared with a combination of tobramycin and cefazolin, and they found that monotherapy with ofloxacin was as effective as a combination therapy. And therefore, it was approved for widespread use. It was commercially available with proven safety, toxicity, and shelf life. But in 1999, we published a report where we showed that there was a progressive development of resistance in Pseudomonas for ciprofloxacin and ofloxacin. Subsequently, there were many more reports of development of resistance among gram-positive as well as gram-negative organisms against first generation of fluoroquinolones. And it was known that this class of antibiotics are becoming insensitive. We brought out fourth generation fluoroquinolone, that is 8-methoxy-6-fluoroquinolones, and it was thought that they have not only superior activity against first generation fluoroquinolone resistant organism, but because of their dual mechanism of resistance, they are less likely to develop resistance. And in 2002, in our laboratory, we found that yes, these drugs were very effective against cipro-resistant gram-positive organism, but they were ineffective against cipro-resistant gram-negative organisms. When we repeated susceptibility in 2010, we found that many of the organisms are now showing resistance to even the fourth generation fluoroquinolone. More recently, we published a study, Asia Cornea Society Infectious Keratitis study, which showed that the fluoroquinolones are increasingly becoming ineffective and against gram-positive as well as gram-negative organisms. There are other studies, AMR surveillance, that have been published and have clearly shown that antimicrobial resistance is a reality even among organisms isolated from ocular infections. But some of the clinicians argue that we are talking about in vitro susceptibility results. And they are based on the serum concentration that is achieved on systemic administration and has no bearing on ocular infection because you are administering drugs directly to the site of infection. You achieve much higher concentration, and therefore there is a high probability of cure even when the infection is caused by drug-resistant microorganisms. We agree that in vitro resistance is a reality, but the two cases that I showed you at the beginning also demonstrate that they translate into in vivo failure of treatment as well. In addition, there are reports that if you use antibiotic indiscriminately or repeatedly in lower than their therapeutic level, your conjunctiva as well as nasopharynx get colonized by drug-resistant organism, clearly indicating that even the ocular or topical administration of drugs can lead to development of resistance among the organisms that are present in our conjunctival cul-de-sac or nasolacrimal duct. So what should be the way forward if we have to handle this kind of challenges. I think way forward is that we should know our enemy and we should become familiar with our weapons. For that, reference laboratories in each geographical area will have to identify important causative organism and determine susceptibility of all of those. And the best parameter for that is to publish list of MIC90 values against important pathogens of ocular infections. And the drug which has the least MIC90 value should be picked up to treat these infections. For example, in this case, the azithromycin has the least MIC90 value, as you can see, same as clarithromycin, and therefore these drugs should be picked up for the treatment of atypical mycobacteria. In addition, you should use smart strategies. And what I mean by smart strategies, you should achieve concentration which are above mutation prevention concentration. And that is why there is a role for fortified antibiotic. And if you use combination of fortified antibiotic, you not only will be able to eradicate infections or organisms which have developed resistance, but will be able to prevent development of resistance in the organisms. And that is the role of fortified antibiotic till we are able to get newer antibiotic. There are other innovations that are happening which will achieve much higher concentration in corneal tissue on topical administration. To conclude, microbial keratitis not only poses several challenges as far as diagnosis is concerned, we have to also deal with antimicrobial resistance, which is progressively becoming a serious concern even in ocular infection. And probably we need a multi-pronged approach to address this challenge. Thank you very much for your kind attention.